pathways you're talking about at 300 days of approval? Is that what you said?
Sorry, I'm not disputing it. I think you were speaking about the pathway perhaps as a whole between launch and perhaps patient access or access to a prescription. I was speaking about your latter comment, which is the amount of time it takes for an approval of a new drug submission, for example, by Health Canada.
So you're familiar with that data. You're not familiar with the data that I'm referencing.
No, I'm sorry, I'm not. I could ask my colleague if he is, if you'd like.
No, that's okay. So am I clear then to say that you don't think there's a problem with accessing new medications in Canada for Canadians? It's a long process.
No, I think what I would say is, refer back to my earlier comments that we do have different pathways for Health Canada to approve
Thanks,
the product.
Madam Boudreau. I mean, I heard that part. Do we or do we not have a problem with the length of time it takes for getting a new drug to be approved in this country?
Well, I referred earlier to the 300 days, and that, in fact, is fairly close to what happens in the U.S. and, in fact, quite close to what happens in the EU.
Yeah, I don't think that's what I asked, though. Do we have a problem or do we not?
Sorry, Mr. Chair, I don't know that I can add anything further to my previous answers.
Okay, fair enough. So on behalf of Canadians, even though there was an opportunity here to change the Canadian Drug Agency and have oversight, the officials and the Minister of Health, in spite of the fact that all Canadians know it takes an excessively long time, as referenced by the data in the study, that you don't think that's a problem. Perhaps that's why we have a problem. The other part that I'll return to is new drug launches in Canada. It appears from the evidence here in front of me that new drugs are not being launched in Canada as frequently in other countries. Do you think that's true?
You are, I guess, looking at some data that I don't have in front of me, so I can't comment on that. But I would like to come back for a moment and just speak about the Canadian Drug Agency and just clarify for the committee that the legislation does not set out the CDA and does not propose a particular mandate or establish the CDA. It speaks to the types of functions that the CDA will do, and it also speaks to a couple of specific functions. And if you'll permit me just to conclude, the CDA is not being contemplated to be an agency that would review drugs, which is done in Health
absolutely. I totally agree with that. The difficulty is that the Canadian Drug Agency could have been mandated to be have better numbers, and you've chosen not to allow that to happen, or at least the minister has.
Thank you, Dr. Ellis. Dr. Pawlowski, please, for 5 minutes.
So our committee is tasked with reviewing this legislation. We're going to go line by line through it. So with that in mind, I kind of read the legislation, and I have what may seem like some mundane questions. There'll be one provision here which I just don't understand what you mean by this. Perhaps you can explain it to me. And let me start off by saying I've been a long-time doctor. I also have a few law degrees, one in health law. I worked for WHO, actually writing health law, and was part of actually drafting some pharmaceutical legislation. And now I've been in Parliament for 5 years. So if there's anyone who should be able to read things and understand it, I would have thought I would have been one of them. And I don't understand this bit. Principles. So the minister is to consider a bunch of principles when they're consulting with the province and territories with implementing national universal pharmacare. And it says one of those principles is to provide universal coverage of pharmaceutical products across Canada. What I don't see within those wording a clear indication. What does that mean? Universal coverage means that every person will receive pharmacare from the government and pharmaceutical products. Which pharmaceutical products? Like all pharmaceutical products? It would seem to me like a very vague, almost like to the extent that it kind of nullifies having any meaning at all. Like what do you mean? What do you mean by that statement? Or that and it says, and it's a rather weird wording, the minister is to consider. Usually it's shall or will consider, but it's is to consider. But what are they supposed to be considering here? What is the goal of that?
And the section sets out principles, as you've set out, and very much as is stated there, the minister, in moving toward the implementation of National Universal Pharmacare. You've heard the minister refer to this as being a first phase. You've heard the minister as well refer to the other section of the bill that speaks to contraceptives and diabetes as part of that first phase. What this does is set up the framework generally for the broader discussions that will take place in a step-by-step manner to create the National Universal Pharmacare program. So universal has the meaning that I think most people would consider it has, which is everyone. So every resident of Canada, everyone who's living here would have access to a Pharmacare program.
Pharmaceutical products isn't defined. So which pharmaceutical products? All pharmaceutical products, or products on an essential drug list? And universal coverage, does that mean that, because we've already talked about this isn't meant to replace when there's an employer who provides pharmaceutical coverage in a pharmaceutical plan, this isn't intended to replace that. But if you say provide universal coverage, it would seem to me to imply that all of us are going to be provided with a Pharmacare program, but that doesn't seem to be the intent. So why put this in? I'm just, again, a little mystified by what's the intent of this section.
If it's helpful, I would refer you to the definition of pharmaceutical product, which is set out in Section 2 of the legislation, and reads as means a prescription drug or related product that is funded in whole or in part through a Pharmacare agreement in which the Government of Canada is a party.
Okay, I'm not sure if that helps me a lot, but let me go on to Article 6. It talks about first dollar coverage. I understand perhaps in the industry there's a recognized definition of first dollar coverage. Again, and you would think I'd be someone who'd be familiar with such a term, but I don't know what it is. What is first dollar coverage?
So you're correct that there is, if I can use the phrase, it's a bit of a term of art within the insurance policy business, and so first dollar means that as soon as an insurable event would occur, so in this case, having a prescription filled, the insurance would apply, i.e. the coverage would apply before any other payments. So in other words, the person coming to the pharmacy is not paying a copay or something first. It's the insurance coverage that would pay that full charge.
Thank you, Ms. Boudreau. Thank you, Dr. Pawlowski. Suite, Monsieur Blanchette-Jonca, pour 2 minutes.
Mr. Blanchette-Jonca, 2.5 minutes, please. Thank you very much, Mr. Chairman. I want to follow up with Ms. Boudreau. You are the person in charge of strategic policy, so you must usually know what people want. Now, we have a very important statement that was made by unanimous resolution in the National Assembly in 2019 that indicates that the National Assembly reiterates that Quebec wants to have its own pharmacare system, calling on the Quebec government to maintain its own system if it is in place, and call for compensation from the federal government. Did you receive this from your officials? I am not aware of that letter. So this is a unanimous resolution from a parliament. Does this not have democratic value? I'm not sure that I've understood your question. I will repeat it. From a democratic point of view, does a unanimous statement from a parliament, does that not have value? I don't have the expertise to answer that question. You're better positioned than I am. So if the Canadian government, for example, adopted a unanimous resolution, would that have an impact from a democratic point of view? I will just come back, if you will allow me, to what the minister already said. Okay, thank you. You understand the importance of a unanimous resolution and the need to act on it. Ms. Boudreau, I want to follow along with my questions. Do you know the Pan-Canadian Drug Alliance? And you understand that it negotiates purchases of drugs to buy them in bulk to get better prices. Is that correct? Yes. So the Pharmacare, I'm sorry, your time is up and more. Mr. Julian, you have 2.5 minutes. Thank you very much. I just want to be sure that you got the resolution from unions in Quebec that came out a few hours ago in favor of Bill C-64. If you didn't get it, I can provide it to you. So the CSN and others, and they are in favor of this bill.
Of the approval process around Health Canada, I thought my Conservative colleague kind of cut you off. And I think it's important for members of the committee to understand. It's a 300-day period for approval through Health Canada from the application date to availability to consumers. I just wanted to understand what you were saying.
Sure. I'm just going to ask my colleague to fill in a little bit, but just to be clear, yes, what I was referring to was the period from where Health Canada would review a drug for authorization in Canada and when it would conclude that review. And then what I was trying to refer to as well is there are other processes that take place typically before a product would be available, say, at a pharmacy. That would include a review that we call the Health Technology Assessment by CADTH or INES at Quebec. And then there would be perhaps some negotiation on pricing. But my colleague can fill in on those other steps as well, if the chair permits.
Yeah, certainly. So in terms of the data that Michelle was referring to, it's the Health Canada regulatory standard of 300 calendar days service and meets that over 99% of the time. And as Michelle mentioned, there are expedited routes in there as well. And then to further on the detail of the rest of the drug approval process, there is the Health Technology Assessment Approval process, which I'm going to refer to the Conference Board of Canada's Access and Time to Patient report. So that's the data that I'll be referencing. It's a January 2024 product, and it identifies that the time to review a product following a notice of compliance from Health Canada through the former CADTH is 246 days. That's 2022 data. Average time spent for products that were waiting to be engaged by the PCPA after, and this is CADTH only data, sorry, I don't have for the INS, was 172 days in 2022, and then an average time spent in the PCPA negotiations of 189 days. So there's different sources on what that total time is, and so you've referenced a data point that, as we said, we don't have that one in front of us. We've got 736 to, I've got another data source that suggests 900, but each of those steps is performing a function.
Thank you,
And so to your
Mr.
point,
McDonald.
oh, sorry.
Thank you. Next.
Just a quick follow-up. What was the shortest
No,
expedited
we're
approval?
well past time, Mr. Julian.
180 days.
Ms. Goodridge, please, for 5 minutes. Yes.
I guess the question is are we going to enforce this? I mean, you told Mr. Julian to stop talking. He still asked the question. He still received an answer. And you know what? I guess if we have rules here, Chair, I would expect that we follow them. If we're not going to follow them, then we'll have utter chaos, which we had with Mr. Julian at the last committee meeting when he chose simply to ignore the rules of the Chair. So I would implore the Chair to enforce those rules, and I would implore my colleague, Mr. Julian, who is want to not follow the rules, to actually follow them and be respectful to the committee.
Point of order, Mr. Chair.
Mr. Julian.
Yes. The last meeting, of course, the chair made a mistake, and I challenged that, which is absolutely appropriate. However, in this case, when an answer is something that all members of the committee want to hear, I think it's the advantage of all members of the committee to actually get that. 180 days. 180 days.
Let's try to get through the last couple of rounds of questions. Mr. Julian's turn is done, and Ms. Goodridge's turn is about to begin. Go ahead, Ms. Goodridge, please.
Thank you, Mr. Chair. So I always find it very interesting to listen to the questions that come from Dr. Pawlowski, and his experience when it comes to medicine is something that I truly do appreciate, and understanding the law background in this is actually further makes it so that I don't feel nearly as stupid, because I also had some of those same exact concerns when it came to reading this bill, and just figured that maybe it was that I didn't necessarily understand it. So my question is, we have a very limited number of definitions in this bill, and yet we are using terms that are relatively new. So why did Health Canada choose not to define first dollar or single payer in this piece of legislation?
So I'll speak first to single payer. It's a term that is used very commonly, and it was used as far back as the 2019 panel report by Dr. Hoskin and that advisory panel. So it's quite a well understood term, and for that reason, there was, in our view, no need to define it. Similarly, for first dollar, as I mentioned, it does have a definition that's quite well understood, and it's not unusual in legislation that if there is a sort of a technical term that's understood within a context, you don't define it, because it has a meaning already.
I appreciate that. So minister is not a defined term that is understood?
That's more of a custom that whoever the minister is that has oversight over legislation, that would typically be set out in the legislation.
Okay, so Indigenous peoples, that's not a defined term?
Again, that's in order to ensure consistent drafting and to respect drafting conventions with other legislation. That's why that term is defined as it is, to be consistent with other legislation throughout the Department of Justice legislation that we have in Canada.
It concerns me, because a piece of legislation should be able to be read as a standalone entity and be understood. And while we have effectively a 4-page pamphlet that is quite light, this is billed by the government as being quite substantive, although we have heard conversation that it's effectively a pilot, so I'm not quite sure what we're actually dealing with here. And so my question is, why the rush? Was it just because of the timeline of the supply and confidence agreement as to why this legislation looks like it was basically pieced together?
No, I can tell you that we worked on the legislation for several months. We work with in fact, probably almost a year. We also work with Department of Justice drafters, with legal drafters, with people that will look at whether the French and the English is consistent. So, in fact, there was a great deal of time spent on developing the legislation.
Was the timeline several months or a year? Because there's a difference between those two.
I'd have to go back and look, to be honest, because it has been a long path for us. But it's certainly been a number of months, and before leading to the legislation, you do all the policy work as well. So.
And I appreciate all of that. And we have a guillotine motion, effectively, of a programming motion. So we have very limited time. And so not understanding whether this was worked on for several months or a year is actually quite important when we're coming to making these decisions. So I would ask that you submit the exact time that this started being worked on to the committee by tomorrow so that we can ensure that we have the adequate information as we're drafting amendments and considering the rest of this bill. My next question is, if it was a year, then that was not enough time to adequately consult with provincial health ministers prior to bringing forward this legislation?
The legislation sets up a framework for that consultation. So if you look at the preamble, a couple of things are important. One is that it's very clear on the jurisdictional work and the role of the provinces and territories, so that is set out very clearly in the preamble. And throughout the legislation, in just about every substantive section, there's a clear statement that there will be consultation with provinces and territories. So this is, in essence, the beginning of those consultations.
Within a day of this legislation being put forward, we had Quebec and Alberta both come out very firmly against and saying that they wanted to opt out of this. Is that not terribly concerning that we have two provinces, and Saskatchewan came along not very far thereafter, indicating their concerns with this? Is that not something that concerns you when provinces are responsible for the delivery of health care by and large in this country, provinces and territories, and they are already opting out, and many of these provinces, all of them in fact, already have their own plans, and there could have been work to try and expand their plans, but instead we have a pamphlet of sorts that is a plan to create a plan to possibly create a piece. So the timelines of when this was worked on is extremely important.
Thank you. We're well past time. If you have a brief response, go ahead.
Simply to point out that there is in the legislation a clear commitment to consult with provinces and territories, a recognition of their jurisdiction, a recognition of their role in drug coverage, and this would build and expand on their coverage, as the minister mentioned. It does not replace it. And finally, just to say that there will be a lot of discussion in the context of bilateral agreements, which is also set out in the legislation.
Thank you. The last round of questions for this panel will come from Mr. Joe Harry for 5 minutes, please.
Thank you, Mr. Chair, and thank you to the officials for the hard work you've done on this and for coming here today. Unfortunately, I'm going to follow on the same theme that my colleague, Dr. Pawlowski, has led us down the path. So in Clause 2 of Bill C-64, Pharmacare is defined to mean a program that provides coverage of prescription drugs and related products. So I understand the prescription drug. And related products, however, are not defined, and I think that may leave a lot of room for interpretation. What does related product means in the context of the Bill C-64?
So related products is referred to also in the pharmaceutical product definition, and it is intended, for example, if you look at the contraceptives, you would find that some of the products that are contraceptives are actually medical devices, so intrauterine devices, for example. So that's the idea with the term related products. And similarly, there could be drug coverage where there would be coverage for something like something like the syringes, for example, if that was chosen. And again, that's not a pharmaceutical product, so that's why that term is used.
You talked about the contraceptive. In Clause 6.1 of the bill, refers to specific prescription drugs and related product intended for contraception or the treatment of diabetes. And I think the two examples that you gave, IUD and the syringes, would be an example of a related product. Is there a list of prescription drugs and a list of related product that will be published later on?
The minister referred to the list in his remarks as well. There is a list that was put forward when the bill was first introduced on February 29th. And as the minister noted, this is the starting point of those discussions with provinces and territories. So yes, there is a list available.
Okay, so there's a list and the list is available. Okay, thank you. Back to Clause 4 of the bill that states the minister must, when working with the Pharmacare partners, to implement national Universal Pharmacare consider principles relating to the accessibility, affordability, appropriate use, and universal coverage of pharmaceutical products across Canada. And the minister must also consider the Canada Health Act. Can you explain the similarity that exists between the principle outlined in Clause 4 of the Bill C-64 and the criteria set out in the Canada Health Act?
Sure. There is some similarity around, for example, accessibility and also universality. There are also some differences, though. So, for example, under the Canada Health Act, we speak of portability, which is not a type of term that you would use when you're speaking of drug coverage. So that the principles that are reflected here are more closely aligned with the principles that would be more appropriate in speaking of drug coverage.
So you talked about portability. Can you explain what that is? That's not included in the Pharmacare under Bill C-64?
Sure. Portability would be like many of us would experience if we are needing to go to a hospital or seeing a doctor in a different province where we're perhaps visiting family or whatever it may be. It's a bit different with a drug plan, because if you're covered under a drug plan, it tends to be the plan that is reimbursed by that province, so you wouldn't necessarily be able to receive the same coverage in another province. So that's what the term portability refers to.
I got about 40 seconds, which I yield back to the chair. Thank you.
Thank you very much, Mr. Johari, and thank you to our officials for staying on. Thanks for all of the work that you've put into this piece of legislation to date and for your service to Canadians. We are going to suspend briefly to allow for this panel to take their leave and for the others to get set up and to have coffee, if you wish. The meeting is suspended. Back to order and welcome our second panel of witnesses. Thank you all for being here. I know that the circumstances didn't allow you to have that much notice, but you're here and in person, and we greatly appreciate that. So we have with us for the next 90 minutes the Canadian Generic Pharmaceutical Association, represented by Jim Keon, President, and Jody Cox, Vice President, Federal and International Affairs, the Canadian Health Coalition, Stephen Staples, National Director, Policy and Advocacy, and Mike Blesky, Advocate Type 1 Diabetes. From the Canadian Life and Health Insurance Association, Stephen Frank, President and CEO, and the Office of the Parliamentary Budget Officer, Yves Giroux, Parliamentary Budget Officer, and Lisa Barkova, Analyst. Welcome to all of you. We're going to invite you to start off with a 5-minute opening statement in the order in which you appear on the notice of meeting. So we're going to start with the Canadian Generic Pharmaceutical Association for 5 minutes. Welcome to the committee. You have the floor.
L'Association canadienne de médicaments génériques et sa division.
The Canadian Generic Pharmaceutical Association thanks the committee for the opportunity to share our perspectives on Bill C-64 and Pharmacare.
And accessible are the key value propositions of generic and biosimilar medicines, which today are used to fill more than 3/4 of all prescriptions in Canada. Expanding the use of generic and biosimilars helps drug plans to fund innovative treatments for patients and contributes to the overall sustainability of drug plans. And, not surprisingly, Maximizing the use of these cost-efficient treatments to help fund Pharmacare was a key recommendation of the Pharmacare Advisory Council report in 2019. We have provided a brief to members and will focus our remarks today on three main areas: the medications to be covered for patients under the proposed Pharmacare regime, guiding principles for bilateral agreements, and bulk purchasing, which has not been defined. To the list of drugs, expanding access to ensure all Canadians can benefit from the life-saving and life-altering medicines they need is an important objective. However, the list of diabetes and contraceptive medications in the February 29th Pharmacare announcement is not comprehensive. There are important gaps that need to be addressed. We have highlighted these in our brief. The current non-comprehensive approach also raises patient equity concerns, as it could lead to suboptimal prescribing to the medicines that are made available to the public for free and lead to suboptimal health outcomes for patients. We are also concerned that the non-comprehensive approach may provide a disincentive for public drug plan formularies to continue their coverage of a broad range of prescription medicines and provide a disincentive to expand coverage to include new drugs in the future. These same concerns apply to drug plans provided by Canadian employers. We recommend that all diabetes drugs and contraceptives that are currently reimbursed by public drug programs in Canada be covered if Pharmacare is implemented. This principle should also apply to medicines added in the future. Guiding principles. Under Bill C-64, the federal government must negotiate and enter into bilateral agreements with individual provinces and territories. An important guiding principle for drug formulary management that is already employed by public drug programs in Canada is to reimburse for only the low-cost alternative product of a pharmaceutical active substance. In order to help ensure the sustainability of the plan, Bill C-64 should be amended to clarify that only generic and biosimilar medicines will be reimbursed once they are authorized for sale by Health Canada and enter the Canadian market. This principle should be included in all bilateral Pharmacare agreements. Bulk purchasing. Bulk purchasing is not defined in Bill C-64. It is not clear what this means. It is important to recognize that Canadian governments already combine their purchasing power to negotiate internationally competitive drug prices for Canadians. They do this through the Pan-Canadian Pharmaceutical Alliance, or PCPA. It is critical that the Pharmacare regime respects the existing pharmaceutical pricing infrastructure to ensure stability of the Canadian drug supply. This will ensure that Canadians continue to benefit from access to both cost-saving generic and biosimilar medicines and the innovative new medicines Canadians need. Prices for generic medicines are controlled through the PCPA tiered pricing framework. This provides a stable and predictable environment for generic manufacturers to continue to provide existing medicines for Canadians and make the investments to launch new cost-saving drugs. According to PCPA, joint efforts between PCPA and CGPA have resulted in savings of more than $4 billion to participating drug plans over the past 10 years. These savings will continue to grow through a new 3-year agreement between CGPA and PCPA that came into force on October 1st of last year. The PCPA also negotiates prices for biosimilar medicines that are set to be significantly lower than the list price for the original biologic drugs. The expanded use of biosimilars has saved public drug plans hundreds of millions of dollars that have been reinvested into coverage for innovative new therapies and the overall sustainability of drug programs. We recommend that governments continue to exercise their power to collectively negotiate drug prices in Canada through the PCPA. In closing, thank you again for inviting the CGPA and its Biosimilars Canada division to appear as a witness on Bill C-64. Jody and I would be pleased to answer any questions you may have. Thank you.
Thank you very much, Mr. Keon. Next, on behalf of the Canadian Health Coalition, Stephen Staples, National Director, I presume will start us off?
Yes.
Okay. Mr. Staples, you have the floor. Welcome to the committee.
Thank you, Mr. Casey. Pleasure to be back here, and dear members of the committee. My name is Steve Staples. I'm the Director of Policy and Advocacy for the Canadian Health Coalition. Founded in 1979, our organization's members work to defend and improve our public health care system. We comprise citizens, frontline healthcare workers unions, community groups, students, and public health care experts. Members of the Canadian Health Coalition welcome the introduction of the Pharmacare Act, Bill C-64. This landmark legislation is an important first step in continuing progress toward a universal national Pharmacare program. Canada is the only country in the developed world that has a universal health care system that does not include universal coverage for prescription drugs outside of hospitals. Pharmacare is needed urgently to improve the lives of those living in Canada. As we've heard, 1 in 5 people reported to Statistics Canada that they do not have access to prescription drug coverage. Importantly, low-wage workers, immigrants, racialized people are hit the hardest. In addition, the overall cost of drugs to the health system must be reduced. According to the PBO, prices for prescription drugs in Canada are roughly 25% higher than the median for OECD countries. And a single-payer pharmacare system with the power of bulk purchasing is the best route to negotiate lower prices from pharmaceutical manufacturers. Canadian Health Coalition members heartily endorse the recommendations of the 2019 National Advisory Council on the Implementation of National Pharmacare, led by Dr. Eric Hoskins, which was referenced earlier. A nationwide program to achieve public coverage for contraception and diabetes medicine and related equipment, delivered by a single-payer approach through provincial health systems, is a historic step in the direction recommended by Hoskins, his report on Pharmacare. But there are many more steps to achieve universal coverage on the National Formulary of Medicines. We urge the government to ensure the legislation adheres to a single-payer national universal public delivery in partnership with provinces and territories, along with adequate funding and accountability measures in accordance with the principles of the Canada Health Act. And I'd like to share the remainder of my time with my colleague, Mike Besky.
Through you, Mr. Chair, thank the opportunity to be here. My name is Mike Blesky, and I've been a type 1 diabetic for 19 years. I'm also a gig worker in my 30s. And as such, like many, I don't have private health insurance, and I either cannot qualify or cannot afford to pay for a plan myself. And although Ontario's benefits cover a portion of my personal expenses, my out-of-pocket costs stand at about $450 a month, mostly from my continuous glucose monitor, which is not covered in Ontario, and my pump supplies. That leaves me with hard decisions about the cost of food and rent at the beginning of every single month. It also leads to situations where I'm forced to consider rationing my supplies, which can lead to health complications. My experience talking to nurses, doctors, and other diabetics across Canada tells me that I am far from alone. Insulin is not a luxury for us. It is a basic necessity for every single type 1 diabetic. Without the proper treatment, we are exposed to complications like debilitating nerve pain, amputation, and permanent blindness. A universal single-payer pharmacare system is the only policy that guarantees that every type 1 diabetic in Canada, regardless of their economic circumstance, can access their life-sustaining therapy when they need it. Policies that attempt to fill gaps only leave more gaps that need to be filled later, such as what we have seen in Ontario with OHIP+. I'm urging this committee to support this bill promptly so that we can get insulin in diabetic hands as soon as possible. And I'm also asking this committee to ensure that syringes, pen needles, pump cannulas, and continuous glucose monitors are fully covered as part of the diabetic supply fund contained in Bill C-64, as these items represent the biggest expenses to most diabetics and in many cases are not part of public coverage in most provinces. I appreciate your time, and we welcome your questions.
Thank you both. Next, the Canadian Life and Health Insurance Association. Mr. Frank, welcome to the committee. You have the floor.
Well, good afternoon. It's a pleasure to be here. My name is Stephen Frank, and I'm pleased to be here today in my role as President and CEO of the Canadian Life and Health Insurance Association. An important part of my job is representing the 27 million Canadians who are covered by workplace and other health benefit plans. Canada's life and health insurers believe all Canadians should be able to access the drugs they've been prescribed. To achieve this, we know that both public and privately funded plans are a necessity. Unfortunately, Bill C-64 falls short of its goal to ensure all Canadians have access to the medications they need. It puts what's working well today at risk. Les régimes de garantie
Workplace benefit plans are an essential pillar of Canada's health system. In the most recent year, life and health insurers paid over 35% of expenditures for prescription drugs in Canada. Our plans cover more drugs than even the most generous public plan. 85% of Canadians have indicated that their health insurance plan allows them to save money, and they don't want any disruptions to it. If they had the choice, they would strongly prefer that the government find ways to provide coverage to those that don't have it.
Who already have drug coverage, I ask members, what will this proposal mean for the average Canadian family? Despite much of the discussion about this bill by various stakeholders, it goes further than contemplating a new Pharmacare program for diabetes and contraceptive drugs. It requires the federal government to begin the rollout of a broad Pharmacare program for an essential medicines list no later than 12 months after the bill gets royal assent. There are material and many unknown risks to disrupting existing programs for millions of Canadians. The Minister of Health has stated that people who have an existing drug plan are going to continue to enjoy the access they have to their drugs. If that's the Minister's intent, it's not at all clear from this bill. As many of the questions reinforced today, its text is ambiguous. It repeatedly calls for universal, single-payer Pharmacare in Canada with no mention of workplace benefit plans. Read in its entirety, the bill could result in practical and even legal barriers to our ability to provide Canadians with the drug benefits that they currently have. For the majority of the Canadians, therefore, this plan, as it's currently written, risks disrupting existing prescription drug coverage paid for by employers, limiting choice, using scarce federal resources to simply replace existing coverage, and leaving a huge gap for uninsured Canadians who rely on other medications beyond diabetic drugs and contraceptives. Now, there is a better way. For example, using the $1.5 billion that has been allocated to this program to target those without coverage would allow the government to provide thousands of medications to several 100,000 Canadians who currently lack drug plans. In other words, we could as a country use scarce federal dollars wisely to make a profound impact on the lives of those who do not have drug plans while protecting the benefits that are currently working so well for the vast majority. So in conclusion, we believe this legislation needs to be significantly amended to focus on ensuring universal drug coverage for all Canadians by addressing any gaps in the drug insurance that currently exists, and to be clear with Canadians about what exactly we're trying to do. I look forward to your questions. Thank you.
And finally, the Parliamentary Budget Officer, Mr. Giroux, welcome to the committee. You have the floor.
Good afternoon, Mr. Chair and members of the committee. We are pleased to be here today to discuss our analysis of Bill C-64, an act respecting Pharmacare. With me today, I have Lisa Barkova, our lead analyst on Pharmacare. If memory serves, this is the first time that I'm appearing before the House of Commons Standing Committee on Health as a Parliamentary Budget Officer, but this is not the first time that the office has responded to requests from the committee regarding Pharmacare. In fact, in response to requests from this committee, in September 2017, my predecessor produced an estimate of the costs to the federal government of implementing a national Pharmacare program. Furthermore, following requests from parliamentarians, my office has prepared an updated cost estimate of a single-payer universal drug plan in October 2023. Je vais maintenant poursuivre en français.
I will continue in French. More recently, on May 15, 2024, we published an estimate of the costs of Bill C-64, which you are considering today, in the first phase of a national universal Pharmacare program. Bill C-64 is proposing to offer single-payer universal first dollar coverage for various drugs, contraceptives, and diabetes drugs. The program intends to improve and expand and not replace provincial and territorial coverage. We estimate the cost at $1.9 billion over 5 years. The estimate assumes that drugs that are already covered by governments and by private insurers will continue to be so. We will be pleased to answer any questions you have on our analysis on Bill C-64 or any other work that we have carried out.
Thank you, Mr. Giroux, and thank you to all of our witnesses today for being respectful of the time limits. I really hope that that's contagious and that it carries over to the parliamentarians in the room for the rest of the meeting. Dr. Ellis, please, for 6 minutes.
Thanks very much, Chair. I've set a timer. So thanks to all the witnesses for being here. Mr. Keon, maybe through you, Chair, I'll start with you. You talked a bit about bulk purchasing, and when we look at the potential medications that are covered here on this list, can you explain to Canadians, I mean, is it likely this is going to result in significant savings and lowering of prices that currently exist?
Thank you. We do not think it will. We do not think it should. We have negotiated a very broad agreement with the Pan-Canadian Pharmaceutical Alliance that covers public drug plans. It's the same price that private insurers pay, and it is a negotiated price with the provinces, the experts from the provinces, that is intended to provide good savings, good prices to Canadians, and a sustainable revenue base for our industry. So, no, we don't think it will provide savings.
Thank you very much for that, Mr. Keon. And to you, Mr. Frank, you know, there's this concept of universal single payer plan here in this Pharmacare pamphlet. Could you tell us, I mean, the minister and the officials who were here previously couldn't tell us what that meant. They said, well, it's a, you know, it's a term that's been used a lot and you know, everybody knows what it means. You know, you've been at this a while and obviously I would suggest that maybe you could shed some light on this for the benefit of all Canadians of what that means.
If there's one point to underline today is that this bill is ambiguous, and we actually don't know what it means because it is not a defined term. But you know, the building of this bill, when you read it in its entirety, references to the Canada Health Act, references in the preamble to previous studies that have been done, single payer mentioned multiple times, universal. Those as a package have been well understood in the courts and over time in the provinces to mean, you know, a single payer, not federal, provincial, private, but a single payer. Universal means the same for everybody. And our concern is that that could be interpreted to also mean that private industry is no longer able to provide coverage. So, you know, when you read this legislation, because of that lack of clarity, because those terms aren't defined, we are concerned with the way it's drafted and thinks it needs to be amended at a very minimum to reflect, if the vision of the minister is what the government's intent is, we would be supportive of that, targeting you know, their efforts on where the need is. But I don't think that we can be confident that that's what the legislation reflects. And so we are quite concerned, and we do believe there's some significant amendments required to reflect what we heard from ministers saying earlier today.
Thanks for that. And through you, Chair, is it fair to say then, Mr. Frank, that our understanding is there's about perhaps 1 or 1.1 million Canadians who lack sufficient coverage. So that could mean that perhaps of the 40 million Canadians, 39 million Canadians that their coverage they currently have could be in jeopardy?
I can only speak to what we cover as a private industry. So there are 27 million Canadians with private drug coverage today in Canada. It's very broad coverage, much broader than even the best public system available across Canada. And they value that coverage greatly. 90% of them value their coverage to a high amount or to a great amount. So they want to protect it, and they are very strongly opposed to having that put at risk. And overwhelmingly, if you ask them what their preferred approach is and you give them a choice, they would like government to target their efforts where the need is. So, you know, we listen to our clients every day. We provide excellent coverage for them. There's 27 million of them that are very happy with what they have, and they don't want to see that put at risk. Everyone would agree people should have access to the medications they need. And so let's target where the problem is, and let's not disrupt what's working well for so many.
Thank you very much for that. And through you, Chair, Monsieur Giroux, thank you for being here. Thank you for your analysis. You know, when we begin to look at federal government spending, We know that the spending is ballooning out of control. That does not mean that Pharmacare is not important. That being said, and we've heard, of course, now from Mr. Keon, there's not going to be any savings here. So this will continue to be an expense to the federal government, of course, to taxpayers. Perhaps we don't have that much time, but maybe you could outline that expense that is going to be a recurring expense to taxpayers with respect to Bill C-64.
Yes, in fact, we estimate the cost to be about $1.9 billion over 5 years, which, yeah, billion. So that means about $400 million ongoing and increasing with population increase and inflation over time. So $400 million per year and increasing, roughly speaking.
And sir, finally, through you, Chair, is it not true that this government has added more to the federal government debt than all other governments combined? I think I've heard that said. Is that true in your analysis?
I'd have to look at the precise numbers, but if it's not that, it's not that far off, due to the pandemic, of course, in good part.
Thank you, sir. My time is up, Chair. It's 5 minutes and 18 seconds. Oh, I have 6 minutes. I apologize. Look, I'm so eager to be good. Wow. So eager to be good. Thanks, Chair. So again, what we've heard is this government is adding significant amounts to the debt and the struggles with Canadians having to pay for that, of course. You know, when we look at this again, Mr. Frank, if you could, on behalf of all Canadians, could you help understand what the difference between a private plan and a public plan is at the current time with respect to percentage of medications that might be covered by a private plan?
Typical private plan will cover almost all medications that have notice of compliance. So a typical plan would cover upwards of about 15,000 different drugs. Typical public program would cover less than half of that, and so that's sort of the delta that you tend to see. What you tend to see in the diabetic space in particular, what you will see is that private plans will cover many of the more sort of innovative, cutting-edge things. So things like weekly injections, fast-acting mealtime injections, insulin specific for diabetic comas, things that are not covered on the public plan, we do cover privately. And that's something that I think when we looked at the list that was published with this Pharmacare Act, we were concerned at how narrow it was. I think others have noted that too. So, you know, the vast majority of Canadians have very, very robust plans, covers essentially everything in the market. And we work really hard to make sure that we're doing that in a sustainable way, and we know that they don't want to see that put at risk with any new government programs.
Thank you, Mr. Frank. Next. Yes, indeed. Mr. Nakvi, please, for 6 minutes.
Thank you very much, Chair. I want to thank all the witnesses for coming here today. I really appreciate it. In particular, I want to thank Mr. Blesky for being here and sharing your lived experience. I think that's the most important, at least for me, in terms of all the testimonies I've heard. I was struck by some of the choices you have to make on a regular basis, given your health and the cost of medication. Can you elaborate a little bit more on some of the challenges that you face currently, and talk to us a little bit about what impact this legislation will make in your life if it passes into law?
Sure. In my case, I know that at one point when I had finished a work contract, I did have private insurance. And when it came time to finish that work contract, I was told by that private insurance provider that because of my pre-existing condition that I was not able to go on to the bridging insurance that would normally be offered to an employee. So therefore, I had to pay significantly more in order to stay on an insurance plan with that company. In another sort of tangential way, I recently started on an insulin pump, so I have been on an insulin pump for about 6 months now. In the months before I was diabetic, and I'm sure Dr. Pawlowski will be able to agree that these numbers are a little bit terrifying, but my A1C before I started my insulin pump was 11.4. The target for being type 1 diabetic is to be under 7. And since starting the insulin pump, my numbers have now improved to 7.7. So that is a huge increase in my personal health. But I made financial sacrifices to do that because of the fact that I knew that I would be paying out of pocket for a lot of these expenses. So one of the things that I've done in the past in order to try and make my dollar stretch was to take my infusion sets, the cannula that goes into my skin to deliver my insulin, and to try and squeeze an extra 2 days out of that infusion set. What that means is I'm risking scar tissue damage on my stomach. And I've seen folks, friends of mine, that have been on insulin pumps that have been in that same situation where they have pock marks all over their stomach and all over their infusion sets because they've had to ration the delivery supplies that they have access to. So those are the kinds of things that you often hear about. There's also the other knock-on effects. When I was talking to different patients from around the country, I actually was talking to, or I got a letter from a family in Prince George who has a 16-year-old son with diabetes. They have not been able to go on vacations since his diagnosis because they put in upwards of $250 plus a month in order to try and pay for their specific supplies in order to keep him healthy. So we see some significant challenges financially, but also in terms of the knock-on health effects of people that don't have access to these medications. And I think that also stretches over to other areas of medications that aren't even in the current wave of this act. And I think that as we start to expand access to medications, I think we'll start to see those upscale or upstream and downstream costs change significantly over time, which will lead to, personal savings in people's pockets as time goes on.
Thank you. Really appreciate that. Come to Mr. Frank. I think you were present in the room, and I asked the minister around the notion around choice and whether this undermines the choice that Canadians would have, or in fact enhances the choice that's available to them. And he was very clear the choice will be maintained, and people have the choice. And this is really clear, creating a floor on two sets of drugs. And there is an important role for private healthcare systems that you are representing. You in your presentation still made the argument. You talked about practical and legal barriers, which I'd like you to elaborate as to what you think are. And are you not satisfied after listening to the minister that choice that Canadians have available right now will not be impacted by this legislation?
Well, I was encouraged by the minister's comments, and I think if we could see that reflected in the legislation, I think we'd be vehemently in accordance with what he has in mind. But we don't see that reflected in this bill. And I think that's the issue that we have. Terms have not been defined. They're used repetitively in different contexts in different ways, and it could be interpreted to mean different things, different sections of the Act. The preamble requires the minister to take into consideration some previous studies that have firmly recommended a universal single-payer Pharmacare program. The Canadian Health Act is referenced throughout. So when you read it in its entirety, creates an enormous amount of uncertainty. And those terms have developed a meaning over time in Canada through the courts, through the provinces, to mean certain things. And so I think we take comfort in what the minister says, but we also would like to see that better reflected in the legislation. And so when you look at, we talked a bit about dental care today. A lot of care was taken with that program to ensure that it was targeted at those who didn't already have coverage. Protections were put in place to ensure employers didn't drop plans. That kind of care and attention, I think, needs to be brought to this legislation so that it actually, over time, doesn't drift away from the intent that the minister described for us today.
Thank you, Mr. Frank and Mr. Nakvi. With Mr. Blanchette.
We will now go to Mr. Blanchette-Jonca for 6 minutes, please. Thank you, Mr. Chairman, and I want to welcome our witnesses for this hour. My first question is for Mr. Giroux, the PPO. I saw your note on May 15th, 2024, on Bill C-64. You say that this first phase will increase spending by $1.9 billion over 5 years. This would imply that the drugs that are provided by the provinces and territories on private plans would be provided under the same conditions. So does that mean that the $1.9 billion will go in particular to provinces that don't have a Pharmacare program, and Quebec and provinces that do have a plan, they will receive less? Well, that does make sense because the plan, as we understand it, and perhaps we don't understand it properly, will complement the plans that already exist and not replace them. So if there is a generous program already in place, then there will be less support. If there is a less generous plan, then more funding will be provided. So if we summarize that, provinces like Quebec, which already has a Pharmacare plan, will be penalized because they already have something in place. Is that correct? That could be the case, depending on the negotiations between the federal government and the provinces. But we can't presuppose what the conclusions of those negotiations might be. Well, this is hypothetical, and there are a lot of hypotheses in politics, as you know. So continuing along those lines, so if negotiations don't go well between Quebec and the federal government on the funding transfers, the province of Quebec may get less than other provinces from this. Can we say, therefore, that Quebec is at a disadvantage? We'd have to look at coverage by province to see whether there is subsidization or overspending in any province. But there's no doubt that spending varies a lot from one province to another. For example, for oral contraceptives, there are provinces that reimburse 20 cents per tablet and others 60 cents. So sometimes there's practically no funding. In the current circumstances, what mechanism would you suggest to ensure that Quebecers get what they deserve for their money? Well, I'm not here to make recommendations. However, the provisions in the bill call for the minister to negotiate with the provinces. I think this is more promising. We know that the negotiations will take place, but we don't know what the conclusions of those will be. So thank you. I agree with you there. I also like to have data. Could the parliamentary budget officer give us data on the various provinces and to see what the spending would have to be to make sure that every province is treated equally for this program? If the committee would like us to do that work, we could consider doing so. If we have refined data that allow us to do so, but we could certainly give a good estimate. Thank you for your usual cooperation. I want to talk about the report that you every year on the financial viability for each province. If we look at the 2023 report, 5 provinces, given their GDP, seem to be viable. 5 others aren't, and the territories are not. 50